Okay. Hello and warm greeting from Tehran. Welcome to our third International Journal Club. In today's session, we will have a discussion on a brilliant article about data set for reporting nasopharyngeal and oropharyngeal carcinomas. I'm honored to have Professor Joss Hille, who is one of the authors of this article, with us today. Professor Joss Hille is a head and neck pathologist and head of Department of Oral and Maxillofacial Pathology in University of Western Cape Town. He is also consultant of WHO Collaboration Center of Oral Cancer and co-writer of WHO Blue Book. Professor Hille, I'm so honored to have you here today. Thanks for accepting our invitation.
You're welcome. I look forward to your analysis of the article.
Is Amir with us?
I don't know. I don't know whether he received the invitation for you. Did you do that?
Okay, I would also like to introduce Dr. Hana Safwa, Associate Professor in the Department of Pathology, School of Medicine in Cancer Institute. I know that, Hana, you're interested in head and neck cancer field. So great to have you here today.
Hello, everybody. Thank you, dear Dr. Mahdavi, from your invitation. It's really my pleasure to participate in this gorgeous and prestigious International Journal Club with dear Professor Hille, and it's really my pleasure to participate in all your international journal clubs, and it's really your kindness. Thank you for having me with your good group in your university. Thank you so much.
You're welcome. We will have first a review of the article that would be presented by Dr. Sepideh Aldaghi, who is a very good and motivated postgraduate student in pathology. And then we will have a discussion about the article. So Dr. Aldaghi, please start.
Thank you. Is my screen shared?
Yes, it is.
Hello, everybody. This is Sepideh Aldaghi, resident of clinical pathology of Tehran University of Medical Sciences. The article I speak about is data set for the reporting of carcinomas of the nasopharynx and oropharynx, explanations and recommendations of the guidelines from the International Collaboration on Cancer Reporting, and it was available in PubMed Central in 2020 August. Professor Joss Hille, head of Oral and Maxillofacial Pathology Department in the University of the Cape Town, and one of the main authors of this article, let me welcome you to this journal club. Your presence is highly appreciated, and it is my honor to be the appraiser of this beneficial practical article today. The topics are abstract, key elements, elements not included, and summary. The International Collaboration on Cancer Reporting was established to internationally unify and standardize the pathologic reporting of cancers based on collected evidence. An expert panel was convened to identify the minimum data set of elements that should be included in cancer reporting from tumors of the nasopharynx and oropharynx, specifically when viral association is taken into account. The presence of the oncogenic viruses such as HPV and EBV in tumors arising in the oropharynx and nasopharynx increase complexity because of their major prognostic significance. The American Joint Committee on Cancer, AJCC, and Union for International Cancer Control, UICC staging systems, which have been designed to have almost complete overlap, are based in the United States and Europe respectively. In order to provide an internationally agreed upon, globally standardized reporting system that goes beyond the various regional and socio-economic settings, the ICCR, International Collaboration on Cancer Reporting Data Sets, were developed. The ICCR data sets aim to ensure that the data set produced for different tumor types have a consistent reporting style and content, using standardized terminology and elements, and contain all the parameters needed to guide management and prognostication for individual cancers. This review focuses on the data set for the nasopharyngeal and oropharyngeal carcinomas, providing a discussion of the key elements that were included, other elements that were not, and explanations of why and how certain elements are critical to the staging of these malignancies, particularly as it relates to HPV and EBV positive tumors. By far, the most significant change in head and neck cancers in the past several decades has been the rise of HPV-positive oropharyngeal squamous cell carcinoma. These tumors have been increasing at about 5% per year, particularly in higher socioeconomic countries among white men. The HPV status of such tumors strongly dictates tumor biology. And after the steady accumulation of evidence showing that this was a distinctive cancer type, it became clear that a unique staging system for these patients was needed. Here in Table 1, there are key elements for pathologic reporting for oropharyngeal and nasopharyngeal carcinomas. For P16 positive oropharyngeal SCC, we should report tumor size and HPV status by P16 immunostaining as acceptable surrogate. And T0 category is used for metastatic P16 positive SCC of unknown primary. For P16 negative oropharyngeal SCC, tumor size, depth of invasion, and tumor grade differentiation are reported. And for nasopharyngeal carcinoma, we should report extension of tumor to local structures, EBV status by EBR in situ hybridization, and T0 category is used for metastatic EBV positive carcinoma of unknown primary. However, HPV status is critical for prognostication and staging. It is somewhat complicated to determine. Overexpression of P16 is a proven prognostic marker in oropharyngeal SCC. And because it is a surrogate for transcriptionally active high-risk HPV in tumors. For this reason, and because it is widely available across practice settings and easy to perform and interpret, it is recognized as a suitable standalone test. For P16 positive oropharyngeal SCC patients, there is no T in situ, and T4 tumors are no longer divided into T4A or T4B. The morphology of HPV positive oropharyngeal SCC is usually distinctive and has been termed non-keratinizing. As it's shown at figure 1, the tumors typically consist of cells with high nuclear to cytoplasmic ratios, forming large nests with pushing borders and little to no stromal reaction. Tumor cells have hyperchromatic round to oval nuclei with inconspicuous nucleoli and exhibit brisk mitotic activity and apoptosis. Most EBV positive nasopharyngeal carcinomas are non-keratinizing, usually with a lymphoepithelial or undifferentiated pattern. As it's shown at figure 2, their cells have indistinct cell borders and vesicular round nuclei with prominent nucleoli. Although morphology strongly correlates with EBV status, but particularly in endemic regions such as Southeast Asia, Even keratinizing or conventional type SCC of the nasopharynx can be EBV positive. The gold standard test for EBV encoded RNA is in situ hybridization on tumor tissue. Here in table 2, there is summary of core and non-core data set reporting elements for nasopharyngeal and oropharyngeal carcinomas. Core elements that are required to be reported are neoadjuvant therapy, operative procedure, specimen submitted, tumor site, tumor dimensions, histologic tumor type, histologic tumor grade, perineural invasion, lymphovascular invasion, margin status, ancillary studies, and pathologic staging. And non-core elements are depth of invasion and coexistent pathology. Many of the classically reported pathologic features of SCC fall away in HPV and EBV positive carcinomas. The primary examples are tumor grade differentiation in situ versus invasive carcinoma and depth of invasion. HPV positive SCCs are poorly differentiated by traditional grading. So providing grading differentiation either provides no additional useful information or is potentially confusing to the clinician. For EBV positive nasopharyngeal carcinomas, the tumors are histologically subtyped but have never been graded according to a maturing differentiation schema. Depth of invasion, although critical for oral cavity SCC staging, is not relevant for HPV positive oropharyngeal SCC, nor is it relevant for nasopharyngeal carcinomas. TMM staging for cancer has been in place since the 1940s and 1950s. And now the two major systems in practice, the HACC and UICC systems, are largely aligned with each other. These systems were developed in the United States and Europe and may not always be applicable to the best practice worldwide. Recent studies suggest that the staging systems may need to change in the future. However, for now, there are not enough data to diverge from them in the current ICCR datasets. The staging for nasopharyngeal and oropharyngeal carcinomas is unique among head and neck tumors because of the specialized anatomy and frequent viral association of these cancers. The ICCR dataset provides staging guidelines that balance the current cutting-edge knowledge in these fields with providing a workable and practical framework that can be used across all practice settings. Some traditional features such as grade differentiation status, depth of invasion, and in situ versus invasive tumor status are not to be reported for virus-positive carcinomas. Widespread use and feedback from users of these new ICCR head and neck data sets will help to validate the data elements and, when necessary, help to refine and improve them further. Thanks for your attention.
Thank you very much, Safide, for your presentation. It was very good. Professor Hille, is there any comments you want to add?
Good morning. Yes, well, thank you very much. Very nice and concise overview of the article. I think that nobody who would have listened to what your student has actually given here would not be compelled not to go and have a look in detail at to what is the literature saying, and especially the article itself that describes the data set, as well as some of the other articles that have subsequently been published. And in particular about the subtypes of squamous cell carcinoma that can be HPV driven, which sometimes can be a bit of a difficulty. And obviously the sensitivity of the detection method, whether these carcinomas are truly HPV driven or not. And then thirdly, also the whole question about whether the current UICC classification is good enough for treatment. yeah, these are the 3 points probably that we may want to address here.
You are muted, Dr. Mahtan.
Oh, yes, thank you. Thank you very much, Professor. I can see that Dr. Afrough has joined us. Professor Amir Afrough is a specialist in head and neck pathology and is a great pathologist who received many awards for his research and works. Hello, Amir. In the article is mentioned that P16 is an alternative for in situ hybridization for HPV detection. I think you have another idea. Can you share it with us?
Hi, good day. Thank you very much, Dr. Al-Daghi, for the brief and concise summary of the article and data set on HPV positive oropharyngeal squamous cell carcinoma. So I believe your question was that is in situ hybridization a sensitive and a specific method for detection of HPV? Is that correct? Well, I think if you mRNA-ish DNA probably is the gold standard for detection of HPV, and from 2014 onwards, it was a very difficult method and it was a very laborious work to use it because you need a lot of troubleshooting. And now, however, nowadays it's now automated on immunohistochemistry platform. And I believe all the countries are going to have access to this. So this is mRNA is actually the gold standard for the detection of high-risk HPV because it will provide HPV in its transcriptionally active form. So with the ish DNA, however, it is a very specific method. It's not as sensitive as that of PCR, so it cannot really amplify low quantities of DNA. So if you have got low quantities of DNA, the ish may not pick that up. So it's not as highly sensitive as you think the DNA ish. But again, the mRNA ish would be the best gold standard to use. Again, PCR on the other hand is very sensitive, but is not as specific as
Yeah, I think that what is obviously important is you know, the mRNA is obviously short-lived. One has to be very careful about the freshness of the tissues when analyzes. So I'm not quite sure. How long do you think the lifetime for messenger RNA is in paraffin-embedded sections? You know, which we can do routine in situ hybridization, because there must be a timeline to that.
So I do not have any experience with that because we have not been using mRNA ish here at our laboratory. But I'm not sure about that. I guess probably 5 years, maybe freshly used paraffin embedded tissue for the last 5 years could be used to retrieve mRNA from the specimens. I'm not really sure about that. Yeah.
Yeah. So for now, what is your advice for countries like ourselves, South Africa, and a lot of Asian countries in Africa, just to do I can't say a fail-safe, but a reasonably reliable, I would say, confirmation of that a tumor indeed is HPV driven? Yeah,
so P16, we currently use P16 as a screening test. I don't know how you're using P16 in your laboratory in Tehran University of Medical Sciences. So P16, it correlates very well with the presence of a transcriptionally active virus, and that's what the College of American Pathologists actually recommends. So if P16 is positive, we then proceed to do additional tests. So if P16 is negative, we use P16 as a screening test. If P16 is negative, there's no need to go and do any other tests, because we know that P16 is almost 100% sensitive. If P16 is negative, as we have shown in our setting, if you have got a low incidence setting, such as our setting in South Africa, we're at Heidelberg Hospital, where we have shown a very low incidence of the virus, you need to go ahead and confirm the presence of the virus either by use of PCR or ISH. So if it is a P16 positive virus, we usually opt to do PCR testing. And if PCR is then positive, we take it as if the virus is present.
Thank you. Dr. Shakir, do you have something to add?
Thank you for the presentation and the comments. I have a question about the comparison between nasopharyngeal carcinoma and oral squamous cell carcinoma. I know that the topic is about nasopharyngeal carcinoma, but unfortunately, oral squamous cell carcinoma is very common in Iran and Tehran. And a question raised about are we supposed to detect HPV in oral squamous cell carcinoma or not? And the other question is about if P16 sensitive and specific to detect HPV. We had a study several months ago on oral squamous cell carcinoma, but it seems that HPV may not be sensitive enough to detect. P16 is not sensitive enough to detect HPV in Iranian population. What do you think about it, Professor Joss and Amir?
Well, let Amir go first on that one. I think he might have probably a most comprehensive answer on that particular question.
So your question is that, if I'm not mistaken, Puyan, is it P16 in oral squamous cell carcinoma, not oropharyngeal squamous cell carcinoma?
Yes.
Is that what you're thinking?
Exactly.
Yeah, so there has been a number of literature on oral squamous cell carcinoma that HPV does not play a significant role in oral cavity squamous cell carcinoma. And even the College of American Pathologists does not recommend P16 testing now in oral squamous cell carcinoma. Because as you know, there is no transition zone in oral cavity proper. So, and a lot of the studies have shown a very low incidence of the virus. So the situation is different for tonsils and base of tongue, where you have got a transition zone, and HPV usually loves to infect transition zones. We are busy now with a study involving the lower lip. As you know, lower lip, you have got the skin on the outside and the mucosa on the inside, and there's a transition zone there. And there is not a lot of studies showing the incidence of high-risk HPV in lip cancer. So that is something we are busy with. And I'm not really sure about how P16 is employed in oral squamous cell carcinomas as per se, because we know that the incidence of HPV is very low in oral squamous cell carcinomas. So, and so P16 might not be a very good surrogate marker for high-risk HPV infection in oral squamous cell carcinomas, as it is expected in oropharyngeal squamous cell carcinoma.
Yeah.
So maybe that's why you're having very not good results with P16s in oral squamous cell carcinomas and being it a very sensitive marker. Anywhere outside of the oropharynx boundary, P16 is not does not have a very good positive predictive value. And the College of American Pathologists does not recommend P16 testing in those areas.
Yeah, it has to do obviously with the whole carcinogenesis of the P16-driven neoplasms. It's a totally different mechanism. This is a once-off transition where all of a sudden the E6, E7 protein basically cascades the P16 production in those cells, and that's why it's so highly positive. Obviously, it's P16 that's ineffective, but it's expressed in high quantities, like, for example, P53 in let's say the oral squamous cell carcinoma, which are mutated through various lines, and where P53 is also a reactive. Well, an aberrant P53 is a reactive expression. So that's why P16 is not used. But you can analyze any tumor with P16, you'll find there might be some positivity because it is a tumor suppressor by all definition in any case. But therefore, the criteria are pretty strict, that you have to have more than 45% of very dark, intensely staining neoplastic cells to actually make the call that that is a P16 positive tumor. But the problem that we're having in South Africa, I'm not just quite sure whether that's to say in Iran, is that a lot of our surgeons still ask for reflex testing on P16 or any squamous cell carcinoma that presents in the oral maxillofacial region. And the pathologists do that, but it's actually not necessary. There's just one caveat though, is that if you do have an overlapping lesion in the oropharynx, and those exist between oropharynx and obviously palatal lesions, that although it may look like that it could be an ordinary squamous cell carcinoma, might one miss, and that's the second point that I wanted to address, is the squamous cell carcinomas that are P16 positive, but actually don't look like it. And yet they are supposedly HPV driven. And a very good article was written by Lewis, who says that, look, there are at least 4 or 5 different variants that have been reported and are recognized as being P16 positive, most likely HPV driven, but are not recognized as such because they might show hints of keratinization, or they, even now the WHO adenosquamous is being mentioned. And I'm just reading here on the latest unpublished edition that the confusion with sarcomatoid spindle cell carcinoma, lymphoepithelial type, or undifferentiated carcinoma, ciliated, papillary, those are types that also are still occasionally arising in that area. And they may, although initially may not possibly be P16 positive or HPV driven, it's still recommended an overlapping lesion one actually does the testing, but that's only basically in the vicinity of the Waldeus ring. But otherwise, it would not. It's a waste at the moment of money, and there's no evidence that P16 has value in anything else in oral maxillofacial regions. So, but the clue is to recognize those variants, and some of them are not already recognizable, and then also and that's the other point I wanted to address in the staging, is that there might be 1 or 2 variants that actually behave more aggressively than your ordinary basaloid non-keratinizing, common variety HPV-driven oropharyngeal carcinoma. And those are the ones with large cells or atypia, or a lot more, let's say, anaplasia than one would normally see in these basaloid squamous cell carcinomas. And those are the ones that might just need some more investigation as to whether they should be treated the same as any other P16 driven squamous cell carcinoma or not. That's the one point. So I think any pathologist needs to be familiar with those subvariants. There's even one that shows reverse keratinization, and that can be easily misinterpreted as an ordinary squamous cell carcinoma, with maybe not as much differentiation as one would normally see, but then misinterpreted as being probably non-P16 positive or non-HPV driven. So there's a very good article that was written, and it is very important that pathologists do recognize these subvarieties. And maybe there's others one as well that will be in future discovered as being truly P16 driven. And we see now in sinonasal area that a lot of other malignant neoplasms now seem to, where P16 expressivity seem to be becoming a focus of attention. And the question is, are they HPV driven or not? And we've seen it in other areas as well. I mean, you've done research on lacrimal tumors, and you're now doing lower lip tumors. So I don't think that we have reached the full spectrum yet of where HPV can actually induce carcinomas.
Thank you. May I add one issue?
Yes, please.
Sorry, I would like, thank you, Professor Just. I would like to highlight one comment Amir mentioned, that the preservation of the specimens is very important at the pathology lab. and it is necessary to fix in paraffin, fix the specimen in formalin precisely if you want to use these specimens for cytogenetic studies. I think it's very important for all of us in path lab to preserve the genetic materials in cells, especially RNA and DNA, to have them in the future for more studies, cytogenetic studies. And it's very important note that Amir well mentioned. Thank you.
Yeah, it all depends if you do have a biobank that preserves frozen tissue. And I think I can advise to start one if you don't have one, at least one central one, where you store specimens that are fresh, possibly. And you can do it with cytology material as well, if that's also quite, if supposedly your sample is a representative. But we are going into the habit now of biobanking most of the tissues that we think are of interest.
But it's very expensive, Professor.
I know it's very expensive because it requires cryo tanks, it requires medical technologists, almost full-time in an employ, space, electricity 24 hours a day. But unfortunately, material does degrade if you leave it at room temperature. You know, and that even deep freezers have been shown not to be, that there is a lifetime to, for example, RNA on it. So yeah, it is expensive, but I think it's the only way to really find the answer to a lot of the questions that we're asking ourselves here. But I think for now, P16, this seems to be a marker that is accepted by the oncologists, because they know if the tumor is P16 driven, then they respond much better. And I think that is what the whole American classification of cancer staging is about, is that is it P16, is it P16 positive or negative? It's P16 positive. And they don't care how many lymph nodes there are in the neck, which I think is a bit of a problem. I've seen cases where ignore the number of lymph nodes in the neck and not staging tumors according to that can result in some problems in getting those patients cured. So there's also still some work to be done there. But you know, that has to be done in countries where there obviously is a wave of these HPV oropharyngeal carcinomas in that target group of youngish or middle-aged professional males, which we're now seeing in South Africa is emerging. Although we still need to really see how much there really is, but we have been able to identify that in South Africa there is indeed a decrease in the conventional squamous cell carcinomas, because unfortunately our cancer registry system does not distinguish between the two. But we've actually been able to express, look at data that show that there is indeed an increase in some of in our population group of HPV, probably HPV-related oropharyngeal cancers, and in general a decrease in the conventional tobacco and alcohol-related squamous cell carcinoma. But that I don't know how the situation is in Iran, you know.
Yes, thank you, Professor. Alcohol consumption is forbidden against the rule in Iran, so we do not have any, record from using it, because if people use it, they will not tell us. So we have not any record from using, but tobacco smoking is quite common.
Yeah, and we still think tobacco is the main driver in any case. Alcohol enhances the risk, but tobacco is the main driver. So, but in South Africa, we've been quite successful in not reducing the total consumption of tobacco, but we've been successful in reducing the per capita reduction in tobacco due to very aggressive anti-tobacco legislation. So, and we see that in our figures. It doesn't mean that our volume of cases is going down because the population is increasing, as always, you know, with refugees and just internal growth. But it shows that so now we're waiting basically the next few years to see if oropharyngeal carcinoma is going to now take over a large portion of our diagnostic, I wouldn't say burden, but yield of oropharyngeal and oral squamous cell carcinomas. I don't think that nasopharyngeal carcinoma, we're not seeing many different changes, and it's not really endemic in this country, although we have a lot of EBV. It's quite ubiquitous. It's not as endemic as in Asian countries. So, and fortunately, now with standard in situ hybridization for EVER, it's quite easy to distinguish those lesions from other non-differentiated carcinomas.
Yes, thank you, Professor. I have also another question. If I understood well, Amir said that you can use HPV, P16 IC staining as a screening test. It was positive. You should go further for each. In this article, it is mentioned that almost 90 to 95% of HPV positive cases have a kind of characteristic histopathologic and clinical view, including being in younger patients, non-smokers, hyperchromatic nuclei in the histological examination. So can we use this as an help? If the test is P16 positive and the case does not include that characteristics, then we should go further for each study or not. You don't use these things as an adjunctive help.
Oh, that's actually a very interesting question. Because the study that we did, we actually compared the P16 positivity also to the keratinizing and the non-keratinizing variants of a squamous cell carcinoma. And therefore, the sensitivity and the specificity of P16 is actually quite improved when you move to the non-keratinizing category. So yes, I think if you get a squamous cell carcinoma that is typically non-keratinizing, like Dr. Al-Daghi showed, it has got that lobular growth, that undifferentiated form with a lot of lymphoid tissue, and it's characteristic of HPV positive, and then the patient also fits the profile. He's much younger than normally the patients who have got tobacco-induced squamous cell carcinomas. Then yes, of course, P16 could just be sufficient in those cases. I think I will not go ahead to do the PCR testing if those stuff are available to me. I mean, the morphology is pathognomonic, and the patient actually fits the profile of HPV positive, having HPV positive oropharyngeal squamous cell carcinoma. Yes, I think in those cases, P16 would be sufficient for testing. Yes.
The only caveat that I would still like to add, there's a bit of a sort of a long shoot, is that we know from other tumors that there are different clones present in carcinomas all over the body, including oral squamous cell carcinomas. And one should not forget that you might sit with a hybrid clone of tumor that might have maybe a large component of P16 positive, but there could be a subclone that might actually be P53 driven, more P53 aberrant type of squamous cell carcinoma, which is associated with the smoking habits of the patient, because who says that all the young patients that present with HPV positive squamous cell carcinomas are not smoking either? So one needs to be still careful about the clinical history of the patient. And I think that for now, what has been decided is that we not de-escalate the treatment for P16 positive oropharyngeal carcinomas, just for that very problematic reason, is that you don't know if you are missing out on another clone that can actually come, that can escape the relatively de-escalated treatment for what a lot of centers now propose is squamous cell, is just radiochemotherapy. And so one needs to be on the guard still for And therefore, one hasn't de-escalated, for example, the dosage, nor the zones or the volume of treatment. And because that has been, I know that a lot of centers, they want to do that, but I think it's not time yet to do so. I don't think that we never know the real biology of what happens else in a patient, especially if they're smoking. So the history still is important. And so yeah, I would guard against. The only thing that we do know that if we have a P16 positive squamous cell carcinoma, the prognosis is better for the patient. But that is also within certain parameters, and I'm not quite sure if the cutoff of 4 lymph nodes versus non-4 lymph nodes actually is adequate. But we'll see. In the next review of the HECC, we'll see probably comments on that when there's more data becoming available. But as for now, I would say it's great if you have, well, not great, but let's say it's better if you have a P16 positive carcinoma of the oropharynx. You have a better prognosis, provided you didn't smoke.
Thank you, Professor. Thank you very much. Hannah, do you have any comments to add?
Thank you very much. I would like to ask a question from dear Professor Hille. I think I thought, based on your article, which was published in Archives of Laboratory and Archives of Pathology and Laboratory Medicine, I think you believe that for every geographic region or every country, we should first determine and design a study about the prevalence of HPV infection, for example, in oropharyngeal region, and then based on the prevalence of HPV positive cases, we have to design a protocol for approaching to HPV positive squamous cell carcinomas of oropharyngeal region. Do you believe that every country or every geographic region has to do these kinds of study in order to access to the prevalence of HPV positive, and then we should decide either to use P16 as a surrogate marker, or we should go further and do something else like PCR study or in situ hybridization? Do you think in this way, this is the right way for us?
I think right now, and Amir, you can comment on this, but I think using P16 now is pretty safe as a routine test, and it's cheap and it's doable if you do immunohistochemistry on a regular basis. So I think you can, for the majority of your cancers, of the oropharynx or pharyngeal regions, you can do your P16 testing, and the oncologist will be very happy with that result. The caveat is, yeah, every region should have its own studies, like we have now seen in the study at Tigerberg, where there might not such a big good positive predictive value of P16 after all. And why is that? Is that what other factors are involved? So, and from that, I think from region to region, we need to find out if what is true and said in America or the USA and in Western Europe is true for the rest of the world. It may not be, you know, but I think for now we are quite happy. And Amir, you can comment on that P16 is a good starter point and is a good, I would say for now, a reasonable good indicator for the prognosis of a patient who presents with a P16 positive squamous cell carcinoma or carcinoma of the oropharynx.
Thank you so much. And I want to ask one question from Professor Afrough. Dear Professor, when you are interpreting P16 IC staining in oropharyngeal squamous cell carcinomas, which percentage do you consider as positive? Because as Professor Hille said, he explained about his opinion, but There are some other percentages also in the literatures. For example, some books consider more than 75% of positive cells being strong and diffuse staining, both cytoplasmic and nuclear staining. And some other studies have mentioned 70%. I saw that in recent WHO, 5th edition of WHO classification, they are going to consider 70% as a very logical percent to interpret HPV positive, P16 positive immunostaining, and even some studies are proposing some other percentages, like even 50% for increasing the reproducibility. What's your opinion when you are interpreting the HPV P16 immunostaining? Which percentage do you consider as positive?
Okay.
And
Thank
if it is positive more than 90% or even 100%, do you decide to go to do further ancillary tests or not? That's just enough.
Yeah. So I'm just would like to go back to your first questions, and then I'll come back to your second question about the prevalence of HPV positive oropharyngeal squamous cell carcinoma. So I think it's quite important to determine the prevalence of HPV positive oropharyngeal squamous cell carcinoma in your region or even at your own hospital, because obviously the type of patients that present to the hospital might be different from types of patients that present in another hospital. So like the study that we did, we found out that the majority of the patients that presented to our hospitals are usually the people of low socioeconomic status. They're the ones that do not have any insurance, and these are the ones who use more alcohol and tobacco other than the common, rather than the common profile of HPV positive oropharyngeal squamous cell carcinomas. And of course, we found a very low incidence of HPV positive oropharyngeal SCC, and we show that P16 actually has got a very low positive predictive value. So P16 is actually not a good surrogate marker for high-risk HPV infection for our setting. So if a P16 is, and majority of these patients, majority of these cancers are actually keratinizing type. So it actually shows us that P16 may be expressed in some of these keratinizing squamous cell carcinomas because the retinoblastoma protein is mutated. That's a possibility, because usually when you have got mutations of RB, you have expression of P16 in these cases. So I think it's very important that you determine the prevalence of HPV oropharyngeal squamous cell carcinoma in your region to determine whether P16 actually has got a very good PPV, so it can be applied on its own as a surrogate marker of high-risk HPV infection. So we did not find P16 to be a very good surrogate marker of high-risk HPV infection at Heidelberg Hospital for now. And what we usually advise oncologists is to go on, and if a cancer is positive for P16, to go on and do PCR specific testing. The question on the positivity for P16. So what I usually like to see is more than 70% positivity in nuclear and cytoplasmic stain. So I'll call that positive. Again, you will have cases where it is like, well, is it 70%? Is it 50 to 60 or 50 to 70%? I will call these cases as equivocal cases, and I still send them for testing for high-risk HPV. So if it is more than 70%, fine, P16 is positive. If it's somewhere between 50 and 70% and the case is a bit equivocal, we will send those ones for testing. So and now we are busy with a study on the, like I said, the percentage of staining is only that applies to the oropharynx, that's what has been recommended by the College of American Pathologists, more than 70% nuclear and cytoplasmic staining. But out of the oral cavity, we don't know that. So now we are busy studying the lip cancer, HPV in lip cancer, and now we have got our own stratification. Is it less than 30% positive, between 30 and 50, and more than 70? We would like to determine what is the percentage of P16 positivity, for example, in HPV positive lip squamous cell carcinoma. So yeah, for oropharynx for now, we should go with the College of American Pathologists, more than 70% testing for positive staining in tumor cells.
And have you ever compared the results between, for example, equivocal cases and results of a PCR test?
Yes, we have had in the study that I did, for example, back at Mass General Hospital, there were a few equivocal cases, and we sent those ones for testing, and we have had a few positive ones. Yes.
Few positive ones.
Yeah, a few positive ones.
Yes.
Yes, that's right.
Thank you so much.
You're welcome.
But I think that is still important. The message is that do not treat those tumors differently from well, the protocol that's been suggested, the AGCC, do not de-escalate your therapy modality depending on whether 75 or increase it or 70-75. I think every oral squamous cell carcinoma or pharyngeal squamous cell carcinoma should be still treated as per conventional modern practices with improved, I don't know what kind of if you have got IMRT in Tehran or not. Radiation therapy is increasing tremendously well.
Yes, we have. Yes, we do.
And so, and that is also very good because that increases obviously the local control a lot. But I don't think that you should deviate from normal oral or basically head and neck cancer protocol for now. I don't think it's good to do that. And you might, and if you get relapses, and as I said, also for the very, very sake of having double clones. I don't know. I also tend to throw in a P53 for comparison. And if my P53 is down tremendously, then I know that there's competition. But some tumors are still P53. I've got a high P53 positivity rate. And so what do you do with that? And also we found that cyclin D1, like high expressivity, also decreases the prognosis of patients, regardless of any kind of squamous cell carcinoma in the area. So there are the other markers as well that we will be studying, for example, macrophage activity, intertumor macrophage activity. So there's a lot of things there that we still haven't unearthed or validated or whatnot. I think for now, the only thing is to say P16 positive, majority of the cancer, if it's not overlapping, the patient has a better prognosis, if it fits the good category.
I just want to add to that, Professor Hille. So I think there is quite a number of trials that have shown that the checkpoint inhibitors, blocking agents, have had a very good success in HPV positive oropharyngeal squamous cell carcinomas, because as you know that a majority of these cancers have got a very huge lymphoid component. So makes these cancers very good targets for checkpoint inhibitors blocking agents. And I think there are some studies that are showing 20% increased survival rates in, so I think in that aspect, maybe I do not agree with you, because maybe these cancers do respond very well to some checkpoint inhibitors. So they might be treated a little bit differently compared to that of conventional squamous cell carcinomas. I'm not sure, we do not yet in South Africa have access to those checkpoint inhibitors, but I'm sure in the US, from what I've seen, there are quite good results with checkpoint inhibitors, blocking agents such as Prezulimab and those other drugs, and they are getting very good success with that. So maybe in the near future, actually having these HPV positive cancer would really affect the type of management of the patients differently. Maybe these patients need to be, there will be different protocols for these patients, I'm sure that immunotherapy is quite a very good choice for these patients. But
unfortunately for South Africa, primary cancer treatment of the primary with checkpoint inhibitors, and we do have them in South Africa, is not yet financed by the medical aid nor by the province. That's a problem. It's only for disseminated cancers. So we haven't got the data to show and to prove that. Maybe in time when it becomes cheaper, that yes, but I would still think that knowing the oncologists, they would still not rely only on that. They would still do the normal radiation chemotherapy protocol, and they will add to it. because of the cost. But only they will add to it if they think they have no local control for now.
Because we know that, for example, there was a study that came out again in the US about a couple of years ago. We know that if a tumor is actually P16 positive, those HPV positive tumors actually do not respond very well to EGFR blocking agents. So because we know that in HPV positive cancers, the E5 gene of the virus results in a stabilization of epidermal growth factor receptor. So those cancers really don't respond to EGFR blocking agents. So so it is very important to know the status of the virus, because these patients need to be managed differently compared to that of your conventional tobacco and alcohol associated squamous cell carcinoma.
Sorry, but dear Professor Afroغ, in some forms of conventional squamous cell carcinomas, in some studies, they have suggested the use of immunocheckpoint inhibitors as well. And in the cases that we have to evaluate the percentage of tumor infiltrating lymphocytes, and based on the presence of tumor infiltrating lymphocytes, they can decide either to treat with immunocheckpoint inhibitors or not. Can we use these techniques for counting HPV positives oropharyngeal cancers as well? I think they're different, because especially in the tonsillar area, we have so many lymphocytes around the tumor, and it's somehow different from conventional oral squamous cell carcinomas. But do you think that treatment with immunocheckpoint inhibitors is more dependent on the percentage of tumor infiltrating lymphocytes rather than positive or negative HPV status?
Yes, this is also a very good question, because I was involved with PD-1 and PD-L1 scoring in conjunctival squamous cell carcinomas. And there, I think they're scored quite differently, the method of scoring, that when you score an oropharyngeal squamous cell carcinoma. So maybe, and that's maybe also different again when you score the oral squamous cell carcinoma. So yeah, I'm not sure if there is now a standard system of approach to counting lymphocytes in HPV positive oropharyngeal squamous cell carcinomas. I haven't really read the literature on that, but I know that Dr. Sarah Pay at Mass General Hospital, she was the first person, I think, to use a standard system and propose a very good standard system for scoring HPV positive oropharyngeal squamous cell carcinoma. We have not done that yet here in our setting, because we do not have the drugs yet, and the oncologists have not yet asked us to score in each and every squamous cell carcinoma. So based on that, I do not have, and I think me and Professor Hille, we both don't have very good experience with scoring these things. So I was actually invited to attend a course on PD-L1 scoring now. So I will see how that will go on. I'm familiar with the scoring system in the eyes. This is because we scored the conjunctival squamous cell carcinomas, but I'm sure the one in the oropharynx is totally different. And maybe even different for oral squamous cell carcinomas, because like I said, HPV positive cancers usually have got a very high lymphoid component, and maybe their scoring would be probably different from that of oral squamous cell carcinomas. And I'm currently, to be honest, I don't know what the standard scoring system is at the moment for those, but I know that Professor Sarah Pay, she was quite like a leading expert in that aspect. Yeah.
Thank you so much.
We haven't received the request yet from the oncologists to do it on primary tumors, only on disseminated. I see that the request is now coming in, or advanced cancers, not controlled, uncontrollable cancers. They still tend to rely on the conventional chemoradiation. So, maybe when the drug becomes cheaper, as Prof. Africa says, then we might get more requests. But as you said, I don't have any experience in scoring PDL in oropharyngeal carcinomas. And who has, frankly? you know.
Yes, yes, yes.
So if you do have it, let us know. You know.
Unfortunately, checkpoint inhibitors are very expensive in our country, and our oncologists tend to use in some patients in advanced cases, particularly in advanced and metastatic setting. But the patient has to pay himself or herself, and insurance companies don't pay, and they are not responsible for these kinds of treatment modalities. And because of the expensiveness of the treatment modalities, so they are not using in routine practice in our country as well.
Yeah, it's cheaper in India, I hear, but that's about it. For now, in Africa also, it's inhibitory expensive, you know. So, but you know, time doesn't stand still.
Yeah.
Maybe a year from now we have a different discussion. Who knows?
Yes, right. Thank you so much.
Dr. Shakib, do you have any comments to add? You're raising your hand.
Yes, thank you. I would like to add one comment about this brilliant article, because we pay more attention to HPV in our discussion, and it is very important. But I think there is an important issue in this article, that some criteria, including depth of invasion, was excluded from reporting template of oropharyngeal squamous cell carcinoma, because oropharyngeal squamous cell carcinoma is usually arise in tonsillar crypts, and this is below the surface, and it is not easy to detect the depth of invasion. And it is very important, it is very crucial to consider the feasibility of the criteria included in the path report. I would like to criticize other the template, especially a College of American Pathologists template, because depth of invasion is not feasible even in oral squamous cell carcinoma, especially in big, great, destructive carcinomas. You don't have access to the normal, adjacent normal tissue, and you are supposed to provide a horizontal line from the basement membrane of the adjacent normal tissue, and you are supposed to measure this line from the tumoralness at the deepest side of the tumor. And I think it is not feasible for the great destructive tumors. I would like to know the idea of Professor Jost and also Amir. What do you think about it? Do you commonly use depth of invasion routinely in your center to report oral squamous cell carcinoma? I think it is a little far from our topic, but what do you think about depth of invasion oral squamous cell carcinoma?
Yeah, we do it routinely. It's becoming one of the most important criteria for deciding whether the patient should have an elective neck dissection or not. So that is, it's almost an overriding criteria now for that decision. For oropharyngeal, the reason why we didn't put it into the article is because most oropharyngeal carcinomas do not get excised. They get treated chemoradiotherapy, so you will never know how deep they were. Whereas for oral squamous cell carcinoma, the prime modality of treatment is still excision. So once you got excision, then you know what your depth of invasion was at the time of the tumor was excised. And the other thing is that, the pattern of invasion determines very much how accurate your measurement of depth of invasion is. If you have a very cohesive or non-cohesive cancer, you may actually misread the depth of invasion. And we've shown it in articles before, especially when you have intertumor distance. of more than 1 millimeter, you need to add that to your actually what you measured. So if you see in ordinary squamous cell carcinoma depth of invasion, let's say 4 millimeters, but you see somewhere else in the same specimen, resection specimen, an intertumor distance of more than 1 millimeter, you have to add that to your 1 millimeter depth of invasion. And then you automatically jump from a 4 to a 5 millimeters. Now, for some centers, that is enough to go for an elective neck dissection. Some centers say, okay, well, let's hold on. But, when you have an aggressive tumor with an aggressive pattern of invasion, you have a depth of invasion 4 millimeters already. At least the surgeons here in Cape Town, they will go for a neck dissection electively, even if there's no evidence of lymphatic invasion. Mm-hmm. But that is because we've seen the specimens, because the primary treatment is surgery. In oropharynx, you only have a biopsy, and we never see. It's only when in overlapping tumors that we do measure it. Yes, then we do. And I've seen oropharyngeal squamous cell carcinoma, which were probably hybrid in terms of some of them were HPV induced and others were conventional squamous cell carcinoma. So which part do you measure? Well, you measure the part that you can measure. And then for that, we use markers. I will use, for example, very sensitive keratin marker, because that will tell me where most of the squamous cells are sitting, what depth from the surface. But these are all extra costs and extra tests to measure in order to be accurate. And it very much depends between some centers. I know that in the private sector here, 4 millimeter is a cutoff point. I'm not quite sure. Amir, what is the current cutoff point at Tigerberg? Is it 5 millimeters or is it still 4 millimeters?
I think it's still 4 millimeters is the cutoff point that we use here at Tigerberg.
Yeah.
I think there is a discrepancy between surgeons and pathologists. We have 5 millimeters as a cutoff point in pathology department. Am I true, Dr. Safar? But surgeons consider 3 millimeter as cutoff point, and they call me several times that is the depth of invasion more than 3 millimeters or not? But we commonly think about in the College of American Pathologists template, 5 millimeter is considered as the cutoff point. And you mentioned that 4 millimeters is the cutoff point to change the pathologic stage classification from I think T1 to T2 or T3.
But you see, that is where the sensitivity lies, in those 3 categories, maybe T1, T2. But once you go to a T3 or T4, it doesn't matter anymore.
Yes.
It overrides. The stage will override everything. But it's only if you really are between T1 and a T2 decision. But if the tumor is already a T2 by size, then it's already by definition, you're not going to really bother about 3 or 4 millimeters. It's only, you see, the thing is that the prognostic criteria that we've devised all work well for T1, T2, maybe some early T3s. But once you go to advanced T3s and T4s, everything falls away. You basically are in salvage territory. And your prognosis diminishes enormously. So don't forget that all of this is based on small tumors. Small, and that's where it becomes important to measure that. So if a surgeon in a T1, clinical T1, ask you if it's 3 or 4 millimeters, I think that you say, listen, it's not 4 millimeters. But if you feel that the patient, and if you've done your other markers, if you look for lymphovascular invasion, which you often do not see in T1 or T2 tumors, it's very difficult. But let's say you have perineural invasion and it's there, and you have a bad pattern of invasion, you may say in a multidisciplinary team, say, listen, maybe it is better to do an elective neck dissection, particularly if the patient keeps on smoking or has got other medical factors that we think that would influence the prognosis of this patient. And maybe tumor infiltrating lymphocytes and macrophage infiltration or even cancer-associated fibroblast activity might come into the equation. I know that, for example, in Sweden, they have now already included tumor budding, and it's even mentioned in the WHO now. The tumor budding now also is a factor to consider whether or not you should start going into an elective neck dissection or not. So Hille has come with that very strongly in the last European conference in pathology that was held last year, where tumor budding is now incorporated into the grading parameters of squamous cell carcinomas. So we'll see in future more of it, but for now, I would say, if you are dealing with a large tumor, everything is overridden by the size, by the stage. It's the T1, T2. That is where the precision medicine will start focusing and becoming successful, but if we catch the tumors early. And that obviously is our goal.
Great. You mean that other adverse pathologic features, including lymphovascular invasion or other perineural invasion, should be considered in T1 and T2 patients, whether lymph neck dissection is necessary or not?
Well, it's very much a call based on the anatomy, and that's a multidisciplinary team that will actually make the final call or advise the surgeon, because sometimes the radiologist might find it's very close to bone, or the oncologist may not like the general medical condition of the patient, and the pathologist may not like the pattern of invasion, or may have measured the P53 activity of the tumors, or you know what, or tumor budding, or it's a grade 5 infiltration pattern with intertumor distance more than 1 millimeter. All these things come into consideration before that decision is being made. Mm-hmm. But I still think that if you have it, for us, for now, if it is 4 millimeter by clearly indicated, clearly demarcated, clearly demonstrable, 4 millimeters or more, it's elective neck dissection.
Mm-hmm. Great.
Can I also add to that, Prof? I do agree with Professor Hille on that. So I think we are always trying to create a standard protocol for everybody, but that is actually, each case should be assessed on its own merit. I think that each case merits its own assessment, because, for example, in the floor of mouth, a depth of invasion of more than 1.5 millimeters becomes very critical because the lymphatics are so much close to the surface. So we cannot really apply the 4 millimeter rule for all the cancers in the oral cavity. And like Professor Hille said, we need to take different also things into consideration. I mean, if a patient is presenting with extranodal extension, we already know that that is a marker of really bad behavior, and that patient is going to expire very soon. So, so yeah, the depth of invasion, I think, depending on the anatomic location, again, it's different.
But you have highlighted here a very important gap in that at the moment there's no literature to say that your depth of invasion cutoff point varies with the anatomical location of the tumor. That is not anywhere yet accepted. Mm-hmm. You know, and that's why it's important to consider the anatomic location of in a multidisciplinary team. And the radiologist who does the CT scans or the MRI also will have a good idea just to see where the tumor is located. You know, but I agree, floral mouth tumors are much more aggressive. You need to treat them a lot more. And the surgeon may say, listen, I already will do a neck dissection regardless of what you guys are saying, because of the fact is that high risk of metastasis.
And also, Amir well highlighted that's personalized cancer therapy instead of a general, common therapy for all cancer patients.
Yes.
Thank you.
So thank you, everyone, and thanks the participants for sharing their time. Kuyan, would you please share the certificates of the panel? So I would like to thank Professor Hille for his presentation, for his presence and his comments. Thank you very much, Professor. It was an honor for us to have you here in this panel.
Thank you. Thank you for having me.
Pleasure is all. And the next certificate for Professor Amir Afougheh. Thank you very much, Dr. Amir, for being here today and participating in this panel.
You're welcome, and I really enjoyed the interaction. Thank you.
Thank you.
We hope to be one day. We hope to be there physically present with you. It's on our bucket list to do, but with the circumstances as they are in the war, that's very not so far away from where you guys are. We decided no, we rather stay a little bit safer. You never know how it escalates.
So we're really waiting for you to see you in Iran. It's a beautiful country. I know you will enjoy it.
Yes, we are. I'm dying to come. I have no qualms about it. It's just when. Yeah, it would be an honor. It would be great.
Honors is mine. I would also like to thank Dr. Hana Safar for your presence and comments. Thank you very much, Hana.
You're welcome, dear Dr. Mahdavi. I would like to thank you all organizers and your dear eminent guests. It was really a pleasure for me. Thank you so much.
Thank you. And lastly, I would like to thank Dr. Aldari, postgraduate students of pathology, for your nice presentation. Thank you very much.
You're welcome, dear Dr. Mahdavi. It was my honor and my pleasure. Thank you very much.
Thank you. And may I ask all the participants to turn on their webcam so we could have a group photo.
Thank you. You know, Professor Hille is very busy these days because he's the head of the scientific committee of a great event in upcoming weeks, and I would like to express my sincere appreciation to him for accepting our invitation. Also, Amir, my great friend.
Thank you.
Thank you. You're welcome.
You're welcome.
So thank you everyone. Have a nice day.
Thank you so much.
Bye-bye.
Bye.
Thank you. Bye-bye. Nice meeting you. Bye-bye.
Thank you.